multidisciplinary workarounds. They're probably the single most important process for managing our hospitalized patients. If you could make rounding more efficient and as a result provide more effective patient care, you'd do it, wouldn't you? Well, we've developed a new way of thinking about the old challenge of multidisciplinary workarounds. The key elements are centered around the idea of playing on a team. Now, we'll be using the terminology of a football team, but you'll see that this could easily be adapted to fit your favorite team sport. Any successful football team depends on the strength of its playbook. Every member of the team needs to know what his or her specific role is and how those responsibilities mesh with the other members of the team. Now, the patient can be thought of as the team owner. The patient's role is to ask questions, make suggestions about care, and actively learn about his or her disease. The senior physician attending is the coach. The attending cares for the patient through the team members by asking guiding questions and encouraging the bedside nurses to actively participate in rounds. Now, out on the field, you've got the quarterback. During rounds, you've got your senior team resident. It's their responsibility to distribute the workload, supervise the interns, and generate the game plan for the day. The running backs are the interns and sub-interns who carry the ball. In this case, they directly care for patients by writing the orders. Of course, a team has little hope of reaching its goals without a strong offensive line, and these are the nurses who operate at maximum potential when they are involved in creating and executing the management plan. And always observing from the sidelines, you've got your assistant coaches. One assistant coach is the case manager who works with the team to create an effective discharge plan and helps head off impediments to care. Another assistant coach is the pharmacist. She helps the team in ordering medications, monitoring potential side effects, and teaching the patient about his medications. Of course, any team's success centers around the quality of the relationships between team members. On the field, that means knowing who's doing the passing and who's doing the receiving. In healthcare, you can think of this as a customer-supplier relationship, and it's not always as obvious as it may be on the field. Take the nurse-physician relationship. You know, I think sometimes we doctors view nurses' role simply as being there to gratify our egos. In reality, it's the physician's responsibility to supply succinct orders and to make sure the nurse understands those orders. When this is the case, the nurse acts as a second line of defense against errors. For instance, if the wrong medication comes through the pharmacy, ideally the nurse can recognize that error and contact the pharmacy. Another important relationship is between the patient and the physician. Now, in our model, the patient is the owner of the team. Just as the team owner thrives on updates from the coaching staff, so does the patient. One of the most valuable exercises for a sports team is viewing game films, thinking objectively about what's working and which tactics need to be reevaluated. As frontline caregivers, we need to continually ask how patient care can be improved. A key question is this of value to my patient? If the answer is no, eliminate it. Let's take a look at a sample workaround that follows our model of teamwork. Mr. Jones, good morning.
Good morning.
How are you? Do you remember me? I'm Dr. Southwick, and this is Dr. Holland, Dr. Bolanos, and Dr. Gady. And this is the case manager, Michelle Lewis, and the pharmacist, Annie Snyder, and you know your nurse, Vicki. We wanted to present at the bedside and discuss your case. Is that okay?
Sure, that'll be fine.
Great.
All right, so as you know, Mr. Jones is our 59-year-old protein chemist who has chronic obstructive lung disease and who was admitted to the hospital for pneumonia. Subjectively, he has felt better over the last 24 hours. His sputum production has decreased, and now he only has scant white sputum production. Objectively, his temperature is 37.2, pulse is 70, respiratory rate of 16, blood pressure 130/80. On his physical exam today, his lung examination only reveals scattered RALs in the left lower lung field, and his E to A changes have now resolved. His white blood cell count has decreased from 14,000 with 90% PMNs to 9,000 with 70% PMNs. His chest x-ray 2 days ago demonstrated a stable left lower lobe infiltrate, and his sputum gram stain revealed gram-positive lancet-shaped diplococci. However, his culture only grew normal throat flora. His urine antigen, though, was positive for strep pneumonia. So for my assessment, Mr. Jones's pneumococcal pneumonia is steadily improving. And my plan, we can discontinue his IV ceftriaxone and continue him on his oral azithromycin alone. And in terms of disposition, if he continues to improve, I think that he could be discharged to home tomorrow.
Great. Mr. Jones, can I take a quick listen to you here? Let me listen to your heart first. Okay, can you sit forward for me? Take big breaths through your mouth. Okay, say E.
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 Right.
So I agree. Why don't we also give him an incentive spirometer, help increase his breathing capacity. Vicki, do you have any concerns for us today?
No, he's been ambulating in the hall without significant shortness of breath. He's eating all his meals. I think a discharge in the morning would be okay.
Is he going to need home oxygen? I noticed his SATs have been a little bit low.
He does have chronic hypoxia with exertion because of his COPD, so he will need home oxygen.
Okay. I can get that set up at home.
Great, great. So, Mr. Jones, do you have any questions at this point?
Everything seems okay. The azithromycin, when I take it, makes me a little bit nauseous. Is there anything else I could get?
So we could actually give amoxicillin, which would effectively treat the pneumococcus.
That should work.
Good.
I would recommend amoxicillin 875 milligrams twice a day for 5 more days, and based on his response to the ceftriaxone and his estimated renal function.
So ordering amoxicillin 875 milligrams PO twice per day for 5 days?
His insurance covers that.
Great. So, Mr. Jones, our plan is switch you to oral amoxicillin today and discharge you tomorrow for another 4 days of antibiotics after that. Now, just to be sure you understand our plan, could you repeat back the plan for you?
I'm going to be on amoxicillin for 5 days, and then I'll probably go home tomorrow, and I'll have oxygen at home.
Exactly. Really good to see you today, and keep up the great work on healing. Now, of course, you're not going to film your daily rounds, but you can improve your performance by assigning an external coach to watch the team at least weekly to assure the team is faithfully following the rounding system. Now, in addition to these 3 principles, team members must be proficient in the fundamentals. That is, the basic skill set unique to whatever activity you are doing. For healthcare, the first key fundamental is learning how to communicate succinctly and accurately. Use the SOAP technique, followed by a brief discussion of the disposition. The SOAP disposition presentation should take only 1 to 3 minutes because the presenter only needs to include key details pertinent to the active problem. Keep in mind that the attending has read the electronic record prior to work rounds. The second key fundamental is utilizing the huddle formation. The team actually forms a circle around the bed, and this huddle emphasizes the importance of all the team members and helps downplay traditional hierarchies. In this way, the huddle creates a zone of safety where everyone feels comfortable sharing their ideas on how to improve the management of the patient. The huddle also creates a shared mental model because everyone hears the same information at the same time, including the patient. So what happens when the rounding program is fully implemented by the team? Our pilot study reveals that both the efficiency and the quality of patient care improves. Patients cared for by the experimental teams had a relative length of stay that was nearly 20% shorter than the control team, and a 30% reduction in 30-day readmission rate from 9% in the control group to nearly 6% in the experimental group. In addition to improving care, we saw a trend toward improved patient satisfaction. And what about the other team members? Nurses felt more respected by physicians and felt that the physicians provided better care to their patients. Residents and attendings agreed that rounds were more efficient, and all the experimental teams achieved an average work round time of under 2 hours. Finally, medical students rated teaching and overall satisfaction with workarounds very highly, while students in the control group rated teaching as being mediocre. Finally, when a team gels, everyone feels a new sense of joy at work. As one intern noted, before the rounding system was implemented, I dreaded coming to work each morning. Now I can't wait to join my team to care for my patients. We hope you will enjoy implementing this team approach to care. Caregivers and patients win. We hope you will review the details of our approach at our website.